Hello, I'm Benjamin Miss, and this is Introduction to Psychology, Therapy, and Treatment. When we consider what this looks like, we kind of often think to here's like Freud's original couch, right? What is therapy? Do we lie on a couch and talk about our thoughts? Does the therapist say, and tell me more, right? Um, what is therapy like? And this segment is going to be on kind of how it developed and different things that are done in terms of therapy and therapeutic techniques and even drugs or new technological things used to treat mental illness. We start with the beginning of the American mental health system, which was through Dorothea Dix. She was a New England woman who looked at kind of, I think it seems like she kind of grew up in mental health issue environment and maybe had some issues herself in her life. She created the first American mental asylums, and this was through intensive lobbying. She was influenced by things she saw in other countries. Um, and we started to see, this. She brought up somebody to Congress who had been a congressman or someone that they had known and was like, this person has severe mental illness. Here they are. I don't know if she brought them or just described living in basically like a basement, tiny room because they're unable to function. There's no care. And interestingly, we know from persuasion that specific examples work much better than generalities. When you have those kind of anecdotal cases. They may not describe things as well, but they draw our attention. She was also involved in nursing during the Civil War. Well, when we look at how things are, a lot of the American we thought of as asylums or mental health, indigent mental health treatment was dismantled in the 1980s, and it was kind of seen as like, look, we're warehousing these people, they're stuck, and yet there was no real follow-up. So it was like, oh, look, we're just going to let them free, coincidentally saving a lot of money for the government, and then now, homelessness, for instance, is a much bigger issue. 1 in 4 individuals in homeless shelters have severe mental illnesses. So when you consider numbers on the streets, people who won't go to shelters, oftentimes these are severe untreated mental illnesses. So clearly, we're at a crossroads where we need to come up with better ways of treating people and offering treatment or offering support, because the research shows that there are people who won't go to homeless shelters. They're too restrictive, too many rules. They're not able to get in. There's not enough of them. People don't feel safe or protected. And interestingly, it's clear that the number one way to keep people from being homeless is to give them homes and just let them do what they do. And yet there's a lot of kind of pushback societal on this, right? Remember the just world hypothesis? People who are homeless deserve to be homeless, so forget them. Well, we look at some other ways of dealing with mental illness, and so we'll go back to the early part of the 20th century. In 1935, a Portuguese physician developed lobotomy. Now, lobotomy was originally done, you see this top image here, they would drill a hole in the side of the skull and inject alcohol, ethanol, basically, to destroy some of the white matter tracts connecting the frontal lobe and the rest of the brain. Well, this went from surgical, popularized by Walter Friedman in the United States, to destructive, to make it easier to perform, and what's called the ice pick lobotomy, which was a horrific thing, controversial from the beginning, but an easy, cheap way to deal with difficult patients. They would lift back the eyelid, jab a ice pick or an ice pick like tool in there, and just destroy the frontal lobe. You can see that image here at the bottom. Back to the eye and just move the ice pick, decimating the frontal lobe. There was a large mortality rate too. This was done on children, people without their consent who were difficult, and it left them with severe mental disabilities, being infantile. Very few of them were able to function, return to work. It lowered initiative and inhibition. And even after people had issues. Many people spoke out against it. It was briefly supported by the medical establishment, and then it became less and less popular. It is considered barbaric, and it is not necessarily ignored today completely. Now, the ice pick lobotomy, the work of Friedman, who basically was loved the publicity. You've seen physicians like that today who sell things that are nonsense. Um, because they love the publicity, they like the money and the power. It just doesn't mean that they're doing good work. And so you see, for instance, celebrity physicians, are they really, people we trust, or are they just really good at selling things? And they do occasionally do lobotomy type things. For instance, psychosurgery does involve affecting the brain, and anything, this is called a cingulotomy, which is the cingulate cortex, the anterior cingulate cortex, which is here, which is associated with, here's the front of the brain, and here's this inner space. So a lot of connections going between the limbic system and the frontal lobe passing through the anterior cingulate cortex. And so they will actually destroy some of that tissue in regards to helping people with severe, untreatable obsessive compulsive disorder. Lobotomy, fortunately, they developed a drug that helped to end lobotomy. And you look at kind of an early advertisement for it. We've been trying to treat mental illness forever. And it wasn't until the late 50s where we developed, society, this drug called Thorazine. Thorazine was the first antipsychotic drug, and it's specifically used to treat things like schizophrenia that previously had no ways to treat. And we'll kind of go into how this works and some of the issues. But in terms of it, it was really kind of the last nail in the coffin of the lobotomy, because it was able to temporarily do what you wanted with lobotomy without the same long-term intractable side effects. Now, there's issues with it. It's not used as commonly today. We got better technology, better drugs. Mental health treatment is extremely common. When you look at the percent of adults receiving treatment, in any given year, it's maybe about half of those that probably need it. And we see that here too, that it's underutilized. That, about half of the people who need treatment are getting treatment. And this is for younger people, for adolescents. A very small number of the young people who need this are really getting treatment. And so we look at just the prevalence of mental health issues and how much we need and help we need on this. When you look at homelessness, a quarter I mentioned had severe mental health disorders, and nearly 800,000 people in U.S. prisons suffer from some type of mental illness. And obviously they're getting very limited treatment, if any treatment at all. Modern treatments include things like psychodynamic therapy, which is based on Freudian, not necessarily the same free association psychoanalysis, which is expensive and not particularly efficacious. But they look at the root of the suffering, right? Like, why are your adult behaviors like this? Can we kind of go back and see why your behaviors are like this, and then come up with maybe some strategies, or at least the idea is to understand our behaviors can help us to deal with them. When we look at things like play therapy, children acting things out with dolls, helping, adults and therapists to see what their issues are. And then we've got behavioral and cognitive therapy, which combine together to what we call cognitive behavioral therapy. These are aspects of it. And CBT is considered to be the most efficacious of the treatments. You look at, what we're doing with these things, and you're looking at what are the thoughts and what are the actions. So consider, do you have anybody in your life who every time you interact with them, you just feel bad, right? Well, CBT would be helping people who aren't as aware of that. Like maybe you have a family member you just kind of avoid because they suck, or something like that, or a long-term friend or something where, they're your friend, but you have to minimize contact, right? Well, people who with, maybe suffering may not be aware of things like that, either people or experiences or environments that are causing them distress. And CBT is helping to identify and develop ways of dealing with this. Now, again, not all conditions are going to be treatable in this way, but it's very helpful. And then there's humanistic, which is looking at the acceptance, awareness. Remember the idea we have positive drives, the ideal self and the real self, and kind of getting those things together. So we're looking at our therapies, right? So we're going to talk about our therapies, pharmaceuticals, and then some of the techniques used. And most people are very supportive of CBT and show that it has great, positive effects. Well, how about for fears? Exposure therapy can work here. Pairing the unconditioned stimulus to the conditioned stimulus. So, maybe someone is terribly afraid of an animal or an insect or something, and they would pair mild exposure with some pleasurable experience, and may end up interacting with the feared thing. If you're so overcome with fear that you can't function, then you might want to work with some kind of exposure therapy. Well, modern things involve the psychopharmaceuticals. That's a big area because it's easy. And these things should almost never be used without therapy and support. And most psychopharmaceuticals, especially for things like depression, should be used short-term in accordance with therapy rather than simply long-term drug treatment, right? Without therapy, these effects are not necessarily going to be as useful, because remember the diathesis stress model, it's the genes and the environment. So if there's a biological cause and environmental cause, treating only one of them won't necessarily be helpful. We're better off adjusting our environments, right? Well, some drugs work much better than others, and they can do different things. They can block the reuptake, right? So here's your neurotransmitters getting put in the synapse, and they're getting pulled back in to be reused. Well, some drugs will block the reuptake, so there's more neurotransmitters available. But again, over time, our synapses are going to adjust. You can block the breakdown, so there's more neurotransmitters available. Or block attachment, so they can't even attach. Drugs used for treating schizophrenia will often traditionally do that. Thorazine would block the synaptic attachment of dopamine. So this would reduce what we call the positive symptoms of schizophrenia, right? Like the hallucinations, the delusions, the odd behaviors. But it wouldn't affect the negative symptoms like flat affect, lack of initiation, anhedonia. It wouldn't help any of those things. So modern drugs, and also the older drugs had risk of what's called tardive dyskinesia. And dyskinesia is a movement disorder where they'd start to develop twitches or tics because of the long-term use of these drugs. The atypical antipsychotics that are newer tend to treat both positive and negative symptoms, but they do have other risks like obesity and drowsiness, and still some risks of neurological side effects too. But the idea is these things are, beneficial in terms of treating or at least helping. Again, the problem is, right, if you're blocking, dopamine, how do people feel about that? Well, we like dopamine. Dopamine is, a feel good, learning, movement, all sorts of positive things associated with dopamine experiences. Drug maintenance and compliance is low in people with schizophrenia because of the side effects. And so they're always looking for and always trying to develop a better medications for schizophrenia. And it's such a big brain change. It's such a very clear neurological indicators that it's one of those things where we very clearly need some kind of help in this regard. So we look at depression and we see, for instance, we've got our antidepressants. And I don't like the word antidepressants for the drugs because they do a lot more. And when we think of what is causing depression, right? Well, you ever hear the phrase chemical imbalance, right? It doesn't. there's much more likely that there's some connectivity issues, some broad network connectivity in the brain that goes way beyond um, chemical, the chemicals, the neurotransmitters themselves. And we also know that the neurotransmitters tend to have, temporary effects, and you can't treat a drug with a or a depression with a neurotransmitter and lead by itself to long-term, the changes in the brain necessary for dealing with depression. Well, again, you need the therapy with it. We look at things like tricyclics. These were the original drugs given for depression. They affected everything in terms of the certain type of chemical, certain type of neurotransmitter, which was serotonin, dopamine, norepinephrine, noradrenaline. They would have these side effects, and more side effects in the modern SSRIs, which specifically affect serotonin, things like Prozac and Zoloft. These can have risks too. All these things tend to reduce sex drive. Serotonin seems to be involved in that. And then you've got atypical antidepressants that affect more than serotonin without the side effects of tricyclics. So again, it's a constant search. Now, Prozac is the least efficacious. It's the most well known. And a lot of times physicians aren't well trained. A physician who's dealing with, like a family physician isn't necessarily well trained in treating mental illness. And so if a patient comes in and like, oh, I'm depressed, my therapist says to get medication, they'll often offer Prozac because that's what's known, and it's the least beneficial. It takes the longest to work. So again, always looking for a better treatment, but even then, trying different drugs is important because there's so many different factors involved in depression, and what makes a person's depression, treatable or needing help. Those are things that really need to be tried out in that way. We also see other conditions. Anxiety is often treated with drugs like Xanax and Valium. These are a class of drugs called benzodiazepines. They are extremely addictive, and so treating anxiety with them is often, these are like a last ditch. Okay, if you have a severe panic attack, take one of these, but that's it, right? And so that's the problem there. Anxiety will often be treated with SSRIs, but high dose SSRIs, higher doses than you take for depression. Bipolar disorder is traditionally treated with lithium. There are some other drugs used. For instance, drugs that are used for seizures are often used to treat bipolar. Lithium is also used for seizures. So it's really interesting things. It suggests some really interesting things. But bipolar is hard to treat because people like these. Oftentimes the manic can feel good, not always, but oftentimes, and so people don't want to tamp that down. Then ADHD is treated with drugs that like Adderall and Ritalin. These are amphetamines, which, ADHD certainly is real, but is way overdiagnosed. And it can decrease appetite, cause difficulty sleeping, and addiction, and just major issues, especially for children treated with these drugs for ADHD. Basically, it needs to be severe, and not finding environmental ways to deal with it before going to drugs. But drugs, well, our culture loves them. We overuse them because they're easy, right? It's like, oh, here, take a drug, boom. All right, let's ask a couple questions. This barbaric procedure involves destroying large portions of the frontal lobe. Is it TMS, ice pick lobotomy, CBT, or ECT? And it is ice pick lobotomy. We've talked about CBT, but not the other things yet, and we will. This was the first antipsychotic medication developed to treat schizophrenia. Is it Ritalin, Xanax, lithium, or Thorazine? And this one is Thorazine. Now, these are all things we should be aware of. You've probably heard of Ritalin, right? People take that for both ADHD, but they also take it as called a study drug. Very, very bad as a study drug. Because it boosts dopamine, people think that they're studying like really, really well, and they're not. People who take study drugs perform worse than people who don't. And high risk of addiction, sleep disruption, all sorts of issues. We should be familiar with Xanax. Also taken recreationally, relaxation, getting high. There's a downstream effect of blocking or boosting GABA has a effect of also boosting dopamine. And it's probably the most well-known after Valium of the benzodiazepines used for anxiety. Lithium is the traditional drug we discuss with bipolar. The problem with lithium is that it can have major side effects in the long term. And so it was a wonder drug when introduced for treating, bipolar disorder. And it's basically just an ion. And then thorazine, right, which we said is the first antipsychotic medication developed, major influence on treatment. Now, we get into some modern technological treatments, and this is my favorite. This is called TMS, which is transcranial magnetic stimulation. This uses, a powerful electromagnet, which is held outside of the head, and basically electrical fields produce magnetic fields. Magnetic fields produce electrical fields. A magnet passes through the skull. Magnetic fields pass through the skull better than electrical fields. And so when you use a TMS, you are creating these powerful magnetic fields that then induce electrical currents in the brain, which can affect the rate of neurons firing. It can alter neurons firing in a way that can create temporary reversible lesions. So, old studies to study the brain would look at brain damage, and then after people were, had this injury, they would take a look at their brain scan and see where the brain was damaged and how they were behaving. They can do that in the lab temporarily to a typical person and have them return to normal functioning very shortly. Now, the side effect, there is a slight risk of seizures in people who've had experience with seizures, but for most people, it's quite safe. You can also increase the rate of neuronal firing, and RTMS has been used to treat some neurological and psychiatric disorders, including major depression. This is a great treatment for major depression for people who have not responded to other treatments. So people who don't respond to drugs, this can actually be quite helpful. They found that using high-frequency TMS, right, RTMS basically, it can be excitatory to neurons and low frequency is inhibitory. Well, the dorsolateral prefrontal cortex, which you see in the image here, on the left side specifically, is part of what we call the approach network, or the behavioral activating system. Basically, we have networks in the brain, and yes, there are hemispheric differences. They're not the personality ones, but they're functional. And so basically, the left hemisphere is part of the approach network, and the right hemisphere is part of the avoid network. Well, people who are depressed are avoid, 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 right? Not doing stuff, not as active in kind of like that reward seeking, very much, lethargy and low energy. So with the TMS, you're boosting the approach. You're basically getting people after very short treatments active, and it creates this kind of reinforcing effect where, hey, I'm doing stuff, I feel better. Oh, I feel better, I'm going to do more stuff. Oh, I'm doing stuff, I'll feel better. Depression is I don't want to do anything, I feel worse. So now I feel like I can't get anything done, I feel worse. It's been shown to increase neuroplasticity, which is the ability of the brain to change, specifically in regards to long-term potentiation, which is involved in learning, a boost in brain activity, and the effect is on the NMDA receptors. These are receptors that are part of the glutamate system. Basically, they found out the receptors by trying different drugs and chemicals and seeing what they affect. Glutamate has different types of receptors, and so in the system, when you kind of boost these, you also increase serotonin and dopamine. You increase learning. You increase the connectivity between the amygdala and the hippocampus, which can do some really powerful things in terms of health. The latched ditch effort is usually electroconvulsive therapy. This has been used for a long time in different ways. They used to do what's called insulin shock therapy, which would create well, much more risky and much more higher risk of death and injury. But basically, people who are you've probably heard people who are diabetic will take insulin because they have trouble breaking down the sugars. If you give a typical person insulin, it will break down so many sugars that they will go into basically shock. We call it insulin shock, because they'll have no glucose available in their blood, and they will pass out, and this will have the same kind of effect. Well, ECT was developed using an electrical system, and it's been dramatized in movies, often as like a torturous device, like One Flew Over the Cuckoo's Nest, where it was used to abuse and control patients. But the modern usage is performed under anesthesia, and it can offer patients immediate relief. So there's nobody's like twitching or like being held down. They're basically anesthetized, and a electrical current is being passed through their brain. This is the best way I can describe it is like turning the brain off and turning it back on again, right? And letting it reboot in the same way as you might have had the experience where your computer freezes or stops working properly, and you turn it off and turn it back on together, and it's somehow fixed. How is it fixed? Well, that's the same issue with ECT. It does appear that it allows for the fast generation of new neurons in the hippocampus, which would be related to memory. And we know that depression is related to a small hippocampus, and that's that part in the brain in the temporal lobe that does memory. We talked about it in terms of amnesia, and so this can, whatever it is, having a very powerful effect. Now we talk about drugs and drug treatment. And so this is a really interesting area too, because it affects a large number of people. $600 billion minimum economic cost in the United States, billions of dollars being spent on drugs, on treatment, on incarceration. Addiction is chronic. People who have addiction tend to, it doesn't it's not curable. It changes the reward pathways in the brain with extremely high relapse rates. Young people tend to have the highest rates of drug use. And when you look at, it's really interesting how it works in different places, right? You have, what's the difference between use and abuse? Well, there are cultures that are what called integrated cultures. The Mediterranean cultures, France, Italy tend to have these types of cultures where people drink and it's not a big deal, right? Children drink alcohol. Pregnant women will sometimes drink alcohol, and it's just not considered to be a big issue because they're not overindulging. They have very few social problems related to alcohol. They have a glass of wine with dinner. In these cultures, it's not atypical to go to lunch and have a beer or a glass of wine and go back to work. In our culture, that'll get you fired in a lot of places. So it's a very different view of alcohol. But you also see that we have what's called the ambivalent relationship type culture with alcohol. Americans tend to engage more in binge drinking. We see this also in British cultures and other cultures where we may have lower alcohol consumption, but more alcohol-related social problems. The movie that we see in the image here being referenced, at the bottom, it's almost like glorified, like the binge drinking, and then the next thing is, where am I? What did I do? Why did I pull up my tooth or get this tattoo? Like all of these kind of like wild consequences, right? So the culture is a really big issue. And we also know that a lot of people's behavior, especially American behavior under alcohol, is giving oneself permission to act in a certain way, right? Now, this is not everybody, right? Sometimes people will be, kind of black out and be, have alcohol used to control them or hurt them. Now, we consider what this means for drugs, and this is Carl Hart, one of the really most influential researchers in regards to drugs and alcohol. And he grew up in poverty and watched his friends become addicted to crack, go to jail, and die. He saw people become seemingly enslaved by crack, right? The kind of crack monster where it's like, okay, somebody smokes crack and now they're an addict. And so he started to study it to see what was so irresistible about it. And so he managed to get a study done at Columbia and they used a hospital, and they put ads in the local newspapers like the Village Voice, offering addicts $950 to spend a few weeks at the hospital and receive free crack made from cocaine, which is just what a great deal for an addict. He was surprised because he'd seen that a lot of people who used crack or meth didn't get addicted. So what was going on here? Now, just a quick aside, we think of addicts as violent, right? But is it the drug that's causing the violence, or is it something else? Well, there was no violence at all from the addicts. So even when they wanted more, they weren't violent. Something odd was happening. Here's a quote from the article on it. At the start of each day, as researchers watched behind a one-way mirror, a nurse would place a certain amount of crack in a pipe. The dose varied daily, and light it. While smoking, the participant was blindfolded, so he couldn't see the size of that day's dose. Then after that sample of crack to start the day, each participant would be offered more opportunities to either smoke the same dose of crack, but each time the offer was made, the participant could also opt for a different reward that they could collect when they left the hospital. Sometimes the reward was $5 in cash. Sometimes it was a $5 voucher for merchandise in a store. So they weren't something they couldn't use right away, but they could use when they left, in addition to what they were being paid. When the dose of crack was fairly high, the subject would typically choose to keep smoking crack during the day. But when the dose was smaller, he would more likely to pass it up for $5 in cash or the voucher. What? Why would a crack addict say, I'm not going to smoke the crack now. I'll take the money in a couple weeks? That doesn't make sense with our expectation of what a crack user looks like. Hart says they didn't fit the caricature of the drug addict who can't stop once he gets a taste. When they were given an alternative to crack, they made rational, economic decisions. They tested crack and methamphetamine addicts, found the same things, and they found that when they offered $20, every single addict chose the cash. They knew they wouldn't receive it till the end of the study, but they were willing to pass up the immediate high, no matter the dose, for a future economic reward. And so we're getting into this idea of economics, right? What does he say about the rats in the lab? The rats that keep pressing the lever for cocaine are the ones who are stressed out because they've been raised in solitary conditions and have no other options. But if you give them, food and let them play with rats and sweets, they stop pressing the lever. Also, 80 to 90% of people are not negatively affected by drugs. People might try cocaine or crack or methamphetamine and just, that's it. They tried it and they're done. But remember, that's 80 to 90%. About 15 to 20% of the population does have this predisposition, the addictive predisposition. So it appears, again, it's both a diathesis stress, genetic and environment. People who have the predisposition, but are maybe raised in an environment that there's no drugs or alcohol, they're not going to become addicts. There's nothing to be addicted to. People who don't have the predisposition, and maybe they're in an environment where there's a lot of it, and they may try something once in a while, and they're just not addicted to it. But look at the economics. For us, if somebody has a severe drinking problem and they're, Irvine, good job, making money, lots of stuff, that's probably the predisposition. If somebody's using a lot of drugs, but they're in poverty, who knows, right? If you don't have economic opportunities, you still want to feel good. And so it might not be irrational in those circumstances for people to get high. And that's the idea here, the expectation, the belief about addicts and addiction and drug use. They're not what we think. Some people have different reasons for using these things. Well, Hart was referencing this old study called Rat Park, which was, again, a really shocking study, controversial. People have interpreted it in different ways, but this is the way I'm going to look at it, right? The life of the lab rat sucks. You're stuck in a cage or a Skinner box, pressing your lever. This is your life. You're stressed out and miserable. So in Rat Park, they gave rats morphine and got them addicted. They were measured to see how much they used, and they were given 2 bottles in their cage, either morphine water or regular water. So they could either get basically high on the morphine, or just have regular water. And so then they put them into Rat Park. And these are images from the study. This is like the rat's fantasy land. So here's your lab rat, and all of a sudden, instead of being stuck in your cage, you're in this, you can run and play with other rats, and there's stimulation and, fun stuff to do, social environment. And then the rats had access to the morphine water or the regular water, right? Well, once they were given a social environment that was akin to some environment where they'd want to be, look at the top. The top solid lines are the caged male and female rats. The bottom dotted lines are the social rats in Rat Park, using far less. Now, they didn't stop using completely all of them. Some of them did. For instance, you'd see the male rats would use it less and less, and the female rats less and less as they were in this environment. But again, they were using it much less. In the same way that someone might have a beer after work, or take a couple of hits and just kind of go about still being social, still being involved. So what's going on with this? Well, what this says is we need social support. We need economic opportunity. When people feel isolated and trapped, then using drugs is not necessarily irrational. An escape might even be a rational thing. When you look at treatment for addiction, now again, this is going to really thinking about the people who have the severe, severe addiction. One of the things is it's very common for people to put into a 28-day treatment, which it doesn't work. 28-day treatments are far, far short. In fact, most research suggests 3 months minimum is a far better treatment, because people need time to rebuild the strategies, the coping strategies, the behavioral therapy. How do you deal with the need to address factors like stress, economic relationships, and legal issues, right? People are coming off drugs. Often they're broke. Their relationships are a mess. They may be facing legal charges. And okay, here's 28-day treatments. Now go. Good luck. It's not going to help to heal things that didn't get broken overnight, right? You can't heal something overnight that didn't get broken overnight. The best way for long-term treatment appears to be social programs like the 12 steps through Alcoholics Anonymous. There is debate about abstinence, mostly because addicts don't want to stop using completely. So if you give an addict the choice, hey, would you like a program that is abstinence or a program where we're just going to help you to drink better? They're generally going to choose that, right? Because, they don't want to give up. They want to stop. They want life to be better. They don't want to give it up. AA works extremely well for people who want to quit. And again, usually treatment is required beforehand in order to help with, getting certain things a little more stable. But these are the 12 steps from Alcoholics Anonymous that are worked through with assistance of other people. And what does it do? It creates this social support environment, right, where you take people who have that predisposition, who have that addiction, who can't stop, and you give them, this kind of support, right? Support and a pathway to do things. And again, we've mentioned before too that with mental disorders, you've got what's called comorbidity, and drug use is often comorbid with things like depression, bipolar, schizophrenia, and other issues, personality disorders. So you see this kind of effect. Well, this is the end of our discussions from Introduction to Psychology, finishing our discussions on therapy and treatment. I strongly encourage everyone to read the OpenStax text. It's free and it's available at that site. It's like OpenStax Psychology. You can find it much more expanded, much more kind of getting into. And whatever area of psychology you're interested in, there'll be more information there. Psychology is huge. Like, we've covered so many different parts of it, different ways of studying the mind and our behavior and our social environment. And I hope you've enjoyed this as much as I have. And I wish you the best in your future education. Thank you.